Good morning. Thank you all for this kind invitation to speak to you this morning and for taking the time to listen to me. There's a timer down here, so I'll try and finish this within the next 15 minutes. And I see they've obviously given me the step again because I'm not as tall as Tobias. So I'm going to talk to you today about value-driven care. For many of you, this is something which has been occupying the space in medical literature. We hear about it all the time when we go for conferences. We understand this is something that companies and governments, especially insurance companies, are looking into. So I'm going to try and explain to you what is value-driven care, why do we need it, and give you an example of how we've implemented it in certain parts of Asia. Now, just a little bit of background to myself. I'm a practicing radiation oncologist. I'm also an associate professor at the School of Medicine, but I spend most of my time in this role called the Group Chief Value Officer. So I'm part of the NUHS cluster, which looks after about 1.5 million people in the western half of Singapore. And my job is to ensure that all these people that we are responsible for get good quality care at a cost that's affordable, not just to the patient, but to the insurance companies and to the Singapore government. So why do we need value-driven care? Our previous speakers have already spoken a lot about this, including our distinguished minister, that we are facing an aging population. In his speech, he said in Thailand in 2050, 60% of the population will be over 60. That's going to happen in Singapore in 2030. So in 12 years' time, when you go to Singapore, 1 in 4 people are going to be over the age of 65. So you can actually just use Singapore as a cautionary tale, as a warning for what's going to happen around the rest of Asia. Similarly, we see changing spectrum of diseases. People are living longer, which is great, but the problem is they're still getting sick. So on average, people still get chronic diseases in the last 10 to 15 years of their life. As Tobias said, we want to live longer, but we want to live healthy, and that's not quite what's happening right now. And as we're moving away from tropical diseases and infection as being the cause of death, we're moving into stuff like cardiovascular disease, cancer, which are another big causes of death, and they're very expensive to treat, and taking long periods of time that the patients need to be treated over. There's also this new introduction of an over-dependence on new technology. We talked about CT scannings and MRIs in Tobias's last talk, but there's a lot of other stuff that we do that which is not really evidence-based, but it seems to be the newest, sexiest things that we want to do. And so we're implementing that without really considering, is it providing us good quality and at what cost? A good example is the Da Vinci robot, which has now been widespread use. Initially, it was designed as a battlefield tool for the US Army, but it's become standard of care for prostate cancer, and people are using it widespread for thyroid cancer, colorectal cancer, hysterectomy, without understanding, is it really more beneficial than just doing a simple laparoscopic surgery in the hands of a well-skilled surgeon? We've also got to deal with more new expensive drugs. Examples being immunotherapy, where in certain countries it is $10,000 a month to keep a patient alive for 4 months. Is that really good quality, cost-effective care? And we've talked about the fact we lack manpower, where we're reducing our birth rates. We're not going to find enough nurses, enough doctors to staff, and when we become old, are there going to be people out there to look after us? So what do we do about this? Many of you have heard of the Professor Michael Porter. So a few years ago, he wrote a paper which seems to have underpinned a lot of healthcare strategies around the world. He talked about this strategy, which is a 6-pronged strategy to try and fix the healthcare system. We're talking about integrating people into integrated practice units, where instead of every hospital duplicating services, we have highly skilled centers for head and neck cancer. We expand excellent services across the geography, so even if you're in Bangkok or in Chiang Mai or in Myanmar, you will get the same level of good quality care. We integrate care across different departments. We move to bundled care payments, which I'll talk about a little bit later. But one thing we don't really do very well in Asia is whether we measure outcomes and costs for every patient at the patient level. Outcomes that matter to the patients, not to the hospitals, not to the payers, but to the actual patient that we're treating. And how do we use technology and information and IT to underpin all this? Now, we heard earlier, and many speakers have talked about the excellent medical tourism that Thailand provides. So why do people come to Thailand? It's because in the patient's mind, they're getting good value care. And what is value? Value is quality divided by the cost that it takes to achieve that. When we talk about quality, we talk about stuff like clinical quality and safety, and we're going to hear lots of talks about that over the next few days. About readmission, how do we lower readmission rates, how do we decrease mortality, how do we prevent a patient from getting a hospital-acquired infection. It's also about appropriateness of care. Was the correct thing done in the correct period of time? Did the patient get a DVT prophylaxis? Was a chest x-ray done within 4 hours for a pneumonia patient who presents at the emergency department? It also has to take into account patient-reported outcomes. So that's a very big thing we don't do very much of in Asia, which is to actually look at our functional score of our patients. How are they actually feeling pre- and post-operations? So that is something called PROMs, which is something we need to start thinking about and collecting. And finally, what is the patient's whole satisfaction of his experience? So that's what we mean by quality. But when we talk about costs, we're not talking about the bill that the patient paid. We're talking from our point of view as the service providers, what it actually costs us to deliver this quality of care. And it has to be measured around the patient level. So you actually have to know, if you do a total knee replacement, what is the actual cost of looking after this patient from the time that the patient first comes to see you in the outpatient clinic, all the way that the patient has his community rehabilitation to the follow-up visits. Measure every touch point, understand what it costs you at every point of time, and if that's the only way you're going to be able to identify waste. And when you start doing that, you're going to realize that a lot of things that you thought were money-making, things that you thought were good for the patient were actually not so. So when you can move down to value-driven care, we're talking about a four-step method that we're trying to do. If you look at it, and I apologize for the words maybe a little bit small, it's actually a very thinly designed quality improvement tool. First, you identify the conditions you want to look into. You define a quality measure, so what exactly is good quality care. You measure the cost at every single touch point to look after the patient. And then you share that with the providers. You share that with the people who are actually doing the work, the nurses, the doctors, and get them to look through this data to understand what they're doing, so benchmarking, how they can improve, and what they should cut down, so reducing waste. And that goes into a continuous cycle, and that's where all our quality initiatives start coming in. Through this, we hope that we can start improving value to the patient, i.e. improving the quality or reducing the cost. The best case scenario, of course, is improving quality while reducing cost, but we do realize that in reality, sometimes cost has to go up at the expense of quality. For instance, if we're not doing a certain test enough, or we're not giving a certain sort of medication, but that is required to improve quality, that's perfectly fine. But what we don't want is situations, and we may not even know they exist, that quality is going down while cost is going up. Because we think we're doing the right things, we don't understand where we're going wrong. Even if we don't benchmark and we don't understand this information, we'll never know that. So these are examples of quality measures. And you can get a lot of these examples from international websites like iCHOM, which they actually are doing a very strong initiative to try and figure out what is good quality care. And what do I mean by good quality care? If you ask anybody, and we talked about it, why do they come to Thailand for medical tourism? Because people would say, it provides me good quality care. Which hospital should I go to? Well, there's Grad, there's a few other major famous hospitals in Thailand, and people say they're good quality care. But what do we mean by good quality care? What does the patient understand by good quality care? It's a lot of times it's gut feel. They look at they listen to their friends, they look at what they feel, they may talk to other doctors, and we'll tell them that. What we're trying to do in the value-driven care movement across the world is actually quantify what is good quality care, such that we can actually measure and benchmark that against other countries and against ourselves. So we could actually say you can get good quality care, total knee replacement in Thailand because there will be no readmission. Your length of stay will be less than 3 days. You will not die, you will not get a complication, you will be able to be functionally very well, and so on and so forth. If we add all this together, then we know that we're providing good quality care. So what I'm saying is that we're trying to move away from just gut feel to actually understanding what actually makes up a good quality care. And we talk about costs. As I mentioned earlier, what we're talking about is measuring costs at every touch point. So what the cost to us to look after a patient in the emergency department all the way to the point that he's discharged from the hospital. Now people say it's very difficult to get all this information. The answer is it isn't. A lot of the information that we talked about actually already exists in a lot of your hospital systems. Many of us use SAP billing tools, and a lot of the information can be already gotten from your SAP. You can understand your utilization from your billing system and your SAP system. You can figure out your quality from your EMR systems, and what drug utilization from your pharmacy systems. So if you're going to embark on this road down value-driven care, it's not that much of an investment per se because a lot of this already exists. You have to combine it all together, use a little bit of computing power, which industry partners can help you with, to produce data that is actionable, and you can actually use commercial tools, for instance, Tableau, to actually get that data out to your clinicians. Now, there are different ways of comparing outcomes and cost. You could use a spider chart like this, where you could use two competing different modalities of treatment for a patient, and you can match, and you can see the results in terms of quality and cost. You can actually even compare surgeons in terms of what their quality they're giving versus their cost. The problem of doing a spider chart like this is that sometimes you don't know which one's more important because we rank everything equally. So like for instance, readmission rates will be ranked up there with weight loss for a certain sort of surgery. So another methodology that people have suggested is something called perfect care index, in which when we measure at the patient level, you have to meet all the quality indicators before you say the case is a success. So going back to our example of a total knee replacement, if the patient doesn't die, doesn't get readmitted, has no complications, but waits longer than 5 days for his operation or 42 days, depending what you've set, that case would be considered a fail. You haven't given perfect care. So if you set 10 indicators, you have to meet all 10 indicators. So that's what we mean by perfect care. Only then do we say for the patient that was a success. So that's another way of measuring quality. You work out all the indicators and you measure how many % of patients meet that. And then you can present it to your departments and to your clinicians. You can do charts like this where we have run lines at the bottom which show each indicator how well they're doing. And the red line on the top actually shows you how many % of patients for that month meet all your indicators. So as a department or as a hospital, you can actually track how well you're doing. You can actually also track whether you're getting better, whether that number of patients who are meeting all the indicators gets better every month. Similarly, you can do it at the doctor level. So you can find out at the surgeon level which surgeon is giving you the best value because his perfect care numbers would be higher and his costs would be lower. So just a quick look at this, you can find out who is doing well, who isn't doing well. And by looking at this information, you can actually start benchmarking your staff to work out how you can improve. The solution isn't to fire the worst surgeon, but to tell him that, look, somebody can do it better than you. How do you become just as good as him? We also use it to track utilization, so we can see which are our tests in the hospital, which is causing us the most amount of money. And we can also use trajectory charts. So you can actually track which services are giving you the most value, how they're doing over time. You can see which services quality is improving, cost is decreasing, and also which services you need to worry about where your quality is decreasing and your cost is also increasing. If you have all the information, that's when all the QI stuff comes in. You can start doing your credentialing, you can start improving your safety protocols, you can start reorganizing, and similarly for costs, you can start reducing non-essential services. But at all times, you have to balance the two. The problem with what a lot of us did in the past was that we focused on one and not the other. We improved quality without realizing what cost it cost us to the hospital, or we started blindly reducing costs without realizing what the impact that had on our patients. So when we talk about value, it is a balance between the two, where you have to know your quality, you have to know your costs, and then you can start working out how do I improve one while not sacrificing the other. And only through that can you start seeing curves like this, where in this group in one of the hospitals, they started implementing new protocols to standardize care. They started working out what they were doing wrong and how they could reduce waste. And as you can see, after the implementation of the new protocol, their quality started going up. So the number of patients who achieved perfect care started increasing, but at the same time, their costs didn't. They were able to rationalize and maintain their cost. And that is what we mean by giving value. So why is that important for those of us who are not treating patients? A lot of companies, insurance companies, and governments, and I believe your minister even alluded to this earlier, are looking into bundle payment. Presently, a lot of us are funded by fee for service, where as long as we provide a service, do an operation, order a test, we get paid for that. That is changing. It's changed already in America. It's changing in a lot of countries around Asia, where we will get paid a fixed amount of money to look after a patient condition, i.e. based around a DRG. For instance, if your patient comes in with a hip fracture, the government would say, I'm only paying you $30,000 US to look after this patient from the time he comes from the emergency department up to 90 days after he's discharged from the hospital. If the patient needs to go to a community hospital, you take the money from the $30,000. If the patient needs to come back for a complication of hip surgery, it comes from that $30,000. If the patient, on the other hand, does very well, stays only 4 days for his hip fracture, goes home, never gets readmitted, is perfectly healthy, you keep the difference between the $30,000 and what it costs you to deliver that care. That is bundle care. It's something that's coming. It's happening in lots of insurance companies, and it's happening in a lot of governments around the world. Why do they want to do bundled care? Because now everybody is responsible. The surgeon will be responsible to try and do a good surgery so that he can avoid readmission rates. The rehabilitation doctor will try to make sure that the patient is healthy, rehabilitated quickly, so he can leave the hospital as well. Our community doctors will be able to look after the patient so they can identify complications early and refer them back to the hospital so we can avoid those sort of readmission rates as well. So everybody is responsible, everybody has a skin in the game. But bundle care only works if you know what quality you're giving, and it also only works if you know what cost you're delivering. So in the future, as we start moving towards this, hospitals in this region will need to know that I do not have high readmission rates, and this is what it costs me, and where can I reduce that care as and when we start moving towards bundle care. So finally, we're just going to talk about a little bit of the ongoing challenges. We do know that cost is hard to achieve. A lot of our hospitals around the system, we do not actually know our costs. We might know what we bill a patient, but we don't know cost because we don't do time-based costing. We don't really know what it costs us to do every day a ward round in the ward. So these are things we may need to start doing. We have a lot of problems with accuracy of data. Unlike the Americans, we don't do our coding very well. It's been something that we've ignored, but it is very important because only through coding will we actually understand our complications and our reimbursements. There are, of course, reluctance from the clinicians because they will say every patient is special. You cannot generalize my patients. Every patient should be different. But in truth, about 90% of most of our patients who come in for any condition are very similar. It's only the 10% outliers that we need to worry about. We don't really know when we talk about bundle payment, is 90 days the correct amount of time? Should it be longer, especially for psychiatric conditions? And I talked about earlier about how we don't really have patient-reported outcomes, which is something we need to start doing in Asia. And so finally, this is where we are. If we start doing value-driven care, which is what most of us are starting to work towards, we can get reports, dashboards, we can identify inefficiencies by benchmarking, we can understand where we need to improve, we can actually do value-based financing, where we can actually tell drug companies, I'm only going to pay this amount of money for this drug because I know what quality it gives and I know against the cost. So we also will have bargaining power against drug companies, technology companies, and tell them to make them meet our needs and talk about costs and money. What we do need, however, is what our friends from Siemens were sharing. We need to start doing modeling. We need to start doing what-if scenarios. We need to start understanding and analyzing what would happen in the future. For instance, we know there's a hurricane going on. Could we have predicted that? Yes. But what should we do then? Should we have canceled the flights? Should we have removed people? Should we move people to a different area? We may be able to do that, but we don't do that very well in healthcare. And finally, where AI comes in is where it's going to start telling us what we should be doing before it even happens. We talked about what we're talking about now is actually treating people in the hospital system. We need to shift them out into the community to prevent them from even coming to the hospital system. So with all this data that we have, how can we use AI and our analysts to start thinking about how we can change the patterns of care in our community, reducing the sugar in the food they eat, reducing the oil that they consume. And these are the things that we need to start doing as we start moving towards value-driven care. Only then can we achieve good quality for minimal cost or a cost that's rational. Thank you very much.